Hi, good evening and good afternoon to everyone. This is Dr. Jenny Galvin, and on behalf of the Online Media Committee, we'd like to welcome you all to our first AAPOS webinar of this academic year. We are welcoming an outstanding panelist of pediatric neuro-ophthalmologists and discussing the adult Neuro-Strabismus unknown cases. I would introduce you to our moderator, Dr. Veliz. Thank you.
Thank you, and welcome you all to this webinar of unknown neuro-ophthalmology and strabismus cases. We have an outstanding panel of very experienced adult strabismus and neuro-ophthalmologists. This is on behalf of the Adult Strabismus Committee of AAPOS, and I want to kind of tell you quickly, the panelists here today, they each one selected a very difficult, challenging neuro case that actually was associated with the strabismus and diplopia. None of the discussers know the case. So these cases are unknown to all of us, including myself. With no further ado, I'm gonna introduce our first speaker, Dr. Hilda Capó, and her case will be discussed by Dr. Jason Peragallo. Hilda.
Hello, welcome everyone. I'm gonna start sharing my screen. I want to thank you for joining us today in this webinar. I hope you find it interesting, and I hope we can all learn something from it. Okay, so I have no financial disclosures. I'm going to start with a case of a 38-year-old woman who presented with binocular diplopia. Her past medical history is significant for a ruptured basilar artery aneurysm in 2006, treated with a titanium coil and a BP shunt. 11 years later, she developed ataxia and was diagnosed with obstructive hydrocephalus. She underwent a BP shunt revision. A year after, in 2018, she developed diplopia. She had a second shunt placed in the fourth ventricle with a Y connector in 2019, followed by a shunt valve replacement and another shunt revision. So after this last shunt revision, she presented to us in December 2019 with an esotropia that measures 25% diopters in primary position. You can notice a V pattern with a esotropia increasing in down gaze and decreasing in up gaze. She also had a right hypertropia of 12% diopters that increased in left gaze and reversed to a left hypertropia in right gaze. Examination with a double Maddox rod revealed 30 degrees of exact torsion in the right eye. So based on this exam, we determined she probably had a bilateral superior oblique palsy. We recommend that for her to come back in 3 months to document stability of her deviation and consider surgery at that time. Well, she did not make it back in 3 months. She had additional surgeries. She had another shunt revision, a replacement of the BP shunt, and a programmable valve. MRI in November 2020 showed that both catheters were in place, and she had a coil mass from the treated superior basilar artery aneurysm. So this is a patient when she comes back 9 months after initial presentation. She has a large angle esotropia of approximately 80% diopters. She's unable to abduct either eye, and she's unable to elevate the eyes, developing a convergent traction nystagmus in up gaze. So I'm gonna go ahead and ask one of the panel discussants to discuss the case and to propose a treatment plan for this patient.
So Dr. Peragallo.
Well, yeah, thank you for asking me to discuss this case. First of all, this poor woman has had 7 shunt procedures. That's incredible, and I can't believe that she went through all of that with the hydrocephalus. Of course, the presentation that you discussed at your initial visit does, I agree, look like bilateral fourth nerve palsies, and the right over left hypertropia looks like she had a V pattern ET, and at that point, you could have considered right greater than left inferior oblique procedures and bilateral medial rectus muscle recessions, but of course she had this ongoing problem with the hydrocephalus and requirement of repeat shunts. So my question is, did she develop the bilateral sixth and paranode from the elevated ICP, or is it just due to surgical manipulation? It's I'm not quite sure, but it's probably due to the elevated ICP most likely. So she's got the bilateral sixth nerve palsies, and then she's unable to look up it with both eyes and has convergence retraction nystagmus, consistent with dorsal midbrain syndrome or paranodes. Since she had these shunt revisions relatively recently, right before you saw her, I would probably wait for some stability again before doing anything surgical. But I would have a long discussion with the patient about what the goals of surgery are going to be. I think that is the goal just getting the eyes straight, looking straight ahead, or with a chin position? Are you going to try to improve the head position as well? And your planning for the surgery is also going to need to require some planning for, are the muscles tight? Are the medial rectus muscles tight? And will you need to assess for that and adjust your plan? So this is really difficult. I mean, she's got bilateral sixth nerve palsies and paralysis of upgaze. So, typically, if she just had the bilateral sixth nerve palsies, I'd consider doing, surgery for the bilateral sixth. So maybe bilateral augmented Himmelsheimer with medial rectus muscle recessions, or full tendon transfer. You could also, if she just had the sixth, you can consider superior rectus muscle transposition with medial rectus muscle recession. But because she has the upgaze palsy as well, you could consider doing maybe, this is so tough, maybe a bilateral augmented Himmelsheimer and medial rectus muscle recession, and then wait and consider doing inferior rectus muscle recessions of the residual halves that you have left. Ed Buckley wrote about doing bilateral inferior rectus muscle recessions for paranodes and had good outcomes. That's something else you could consider. So I'm really interested in seeing what you decided to do.
Thank you, Dr. Paragallo. So Hilda, can you continue with your case?
Sure. See, my slides are not advancing now. Okay, here we go. So as I said, what is going on with this patient? Thank you first for all your thoughtful insight on this patient. So she does have the upgaze palsy, and I agree with you. Our impression was that she did have a Parina's syndrome. As we know, the vertical center is located at the junction of the thalamus and the midbrain. And there's a classic triad with impaired upgaze, convergence retraction nystagmus, and the pupillary hyperreflexia. So causes of this Parina's syndrome, most common ones are pineal gland tumors, midbrain infarction or hemorrhage, AV malformations, multiple sclerosis, encephalitis, trauma, or obstructive hydrocephalus, as in our patient. So with regards of the esotropia with the abduction deficit, this was a bit more tricky. So initially we thought this is definitely an abducens palsy, a bilateral sixth nerve palsy due to dysfunction of the sixth cranial nerve. But there is also something called pseudo-abducens palsy. And this is poor abduction that is not due to dysfunction of the sixth cranial nerve. In these patients, there's a lesion in the thalamus or the mesodiencephalic junction. And what happens is that there are convergence pathways that descend from the temporal parietal occipital junction. They go down through the thalamus to the rostral midbrain and synapse with the medial rectus subnuclei of the oculomotor nerve. So if there is injury to these descending inhibitory pathways for convergence, this will lead to impaired medial rectus inhibition, causing excessive convergence and abduction deficit, even if the innervation to the lateral rectus muscle is normal. So what can we do about this? We'll see. There's something called a peering at the tip of the nose sign. And I think this is what our patient has. He had a combination of forced downward deviation and convergence. And this is often associated with abduction deficits, as in our patient. But in this case, it is thought that that abduction deficit is secondary to the pseudo-abducens palsy. These cases are highly suggestive of thalamic hemorrhage, which our patient did not have according to the MRI. So it would have been probably related to her hydrocephalus. And is thought to reflect damage to the mesodiencephalic junction, which contains structures important for both the vertical gaze and divergence, as we saw. So this would explain all the findings in our patient in the same anatomic location. In terms of treatment, As Dr. Paragallo already mentioned, Dr. Buckley has this paper. He looked at the surgical treatment of Donoghue palsy in Perry-Nutt syndrome, and he analyzed 3 different options. You can do full tendon transposition of the horizontal muscles to the superior rectus insertion. You can just do inferior rectus resection of 6 millimeters, or you can do a combination of the resection of the inferior rectus with a resection of the superior rectus muscle. He found that no procedure was obviously superior, and all 3 of them did improve outcomes. He found that adding the superior rectus resection did not increase the effect, but it did decrease the amount of depression, which is an important position of gaze. And he thought that transpositions were more complex, but allowed to address the elevation defect and horizontal deviations with 1 procedure. We didn't think that a transposition was going to be helpful in our patient due to the large angle of esotropia. What about the treatment of the esotropia and the abduction deficit? Well, if she has a complete 6-nerve palsy, as Dr. Paragallo mentioned, she probably will need a transposition of the vertical recti, and it can be partial or full tendon. It can be with or without a recession of the medial rectus muscle. What about the pseudoabducens palsy? This is her situation where I couldn't find much information. I don't have much experience with that. So we said, what can we do? Back to your question, I think what really bothered her was the fact she could not even get her head straight. She was really bothered by the abnormal head position. So I decided I definitely had to recess both inferior rectus muscles. And why not recess the medials at the same time and see what happens and take it from there? I can always do a transposition later on. So that's what we did. On December of 2020, we went ahead and we did a large resection of both medials and a large resection of both inferior rectus muscles. So this was the outcome 1 month after the surgery. She had a small residual esotropia of only 14 prism diopters, which kind of really suggested that what she had was a pseudoabducens palsy to start with, and she had a small right hypertropia. However, she still has some diplopia with some torsional component. And we decided, well, can we do additional surgery to help this woman? And how can we determine if surgery will be useful? Well, we use a white disc test, which was recently published in February. And I think it's a very useful test in the absence of a synoptophore. So it evaluates fusional potential in patients with torsional diplopia. You present a white disc on a black background in a dark room that would eliminate the perception of torsion, and then you neutralize horizontal and vertical misalignment if necessary. If the patient reports absence of diplopia on the white disc test, that establishes the ability to fuse. So the patient was able to fuse when we neutralized her deviation, and we said, okay, let's try a second surgery. She was very motivated. She wanted to go into rehab, and she wanted just to get better. So we did a second surgery, did a resection of the right inferior oblique and a haraita of the right superior oblique. Actually, let me go back for a second. Yeah, but here she still had 20 degrees of extraocular torsion. And I wanted to mention, I think the extraocular torsion, you remember initially was 30. You went down to 20, I think related to the inferior rectus recession that has causes extraocular torsion. So when you recess it, you can decrease the extraocular torsion. So anyway,
we have 1 minute left.
Okay, the second surgery, we did a resection of the right inferior oblique, a haraita, and a resection of the right lateral rectus with an adjustable suture. Now she's able to fuse a very small intermediate esotropia at distance and a small intermediate XD at near. And I'll try to show you her video. This is after surgery. She saw a little difficulty going over to the right. She goes pretty well to the left. She prefers a mild right face turn. And we'll see if we have time to get to the up gaze. She still has a little bit of convergence retraction in nystagmus in up gaze and some vertical nystagmus in down gaze. So with her head position, her alignment is excellent. She no longer has a chin up head posture and she's going up. There's another one you see better, but you can see a bit of convergence looking up and her nystagmus there. And there's some nystagmus with her looking down. And then she holds her eyelids with her fingers and you can see it a little bit better. So I think she had, and this was done with telemedicine. It shows you that telemedicine can be useful. She lives far from the institute, so I didn't want to get her, I had to come all the way back, but I wanted to get a video on her. So that's looking down, and we'll just finish with her looking up one more time. So telemedicine can be useful even for post-op patients. Some interaction of the left superior oblique, some more interaction of the right superior oblique, and now she's going to look up, and you can see a little bit of a convergence on a tented up gaze. There she goes. Okay, so I think in summary, I think she did pretty well considering her condition. And I think it was interesting concept of the pseudoabducens palsy. Thank you for your attention.
Thank you, Hilda. Our next presenter is Dr. Sean Donoghue, and he's presentation will be discussed by Dr. Linda Donoghue. So Dr. Donoghue.
Oh, let me stop sharing.
Thank you. I appreciate it. I'm pulling my screen up here. Thank you for asking me to be part of this. I'm certainly thrilled to be involved. I want to talk to you about a challenging case of management of mild, which then became moderate and residual bilateral superior oblique palsies. This is a patient who's a 55-year-old man, severely and morbidly obese, who came in originally back about 10 years ago, complaining of severe headache, distance diplopia, and tinnitus, chronic pain. He had dilated conjunctival vessels and episcleral veins. And as a result, the neuro-ophthalmologist who saw him was concerned about a possible fistula, ordered MRI and CTA. And even though both the MRI and CTA were read as normal and looked normal when the neuro-ophthalmologist and I both looked at them, the superior ophthalmic veins were enlarged. And so we proceeded with a CC fistula, which demonstrated, with a angiogram, which showed a CC fistula. He had 3 different embolizations from 2015 and 2017, and then presented to us the first time in strabismus about 4 years ago. And his motility is here, and this is before EPIC. And you can see he has bilateral abduction deficits, but both of them are relatively small, -1 on the right and -2 on the left, and slow abducting saccades. And if we have some time, we'll talk about slowness of the abducting saccade with respect to the forces of abduction there. And you can see he has a large esotropia that increases in left gaze, and a distance near disparity where the ET is greater at distance than near. And that tells me that this is neurologic in nature. Now, we already know this is neurologic in nature. There's 6 nerve palsy. But the question becomes treatment. And this is kind of where I got into trouble and needed some help. And that's the purpose of this. But I did not want, at this point in time, with the small angle amount of abduction deficit, and with the relatively small deviation in primary position, to do bilateral transpositions. So the first procedure I did was bilateral 7 or 8 millimeter resections of both lateral rectus. Normally I wouldn't do that. I would have done a recess resect. And if the versions were full, I would have done bimedials. But because of the abduction deficits and the slow abducting saccades, I tightened both laterals. He came back 6 weeks later, was ortho, no diplopia, was doing great. But unfortunately, 2 months after surgery, he recurred, and his diplopia recurred, the headaches recurred. First thing you think of, does he have recurrent fistula? He's been embolized 3 times. We repeated the angio. There was no new fistula, but he now had a left-sided abduction deficit and a 15 prism diopter relatively competent ESO. At that point, I set both medials back. I recessed both medials 4.5 millimeters for 20 prism diopters of esotropia. And post-operatively, he was doing great and did great with full versions and no double vision for about 1.5 years. And then came in to see us. Now he's 13 months post-op from the second surgery. The first one was bilateral lateral rectus resections. The second bilateral medial rectus recessions, complaining only of double vision on left gaze. And he has this left-sided abduction deficit, a very small ESO in primary position, but it gets pretty big on left gaze. He fused in primary with a 4 prism diopter Fresnel, and I put that on him, but he just wasn't happy because as soon as he moved into left gaze, he started getting double. And so the question I have for the panelists is, what do we do now? So we've got a residual abduction deficit in somebody who's known bilateral 6 nerve palsies, who's had bilateral lateral rectus resections and bilateral medial rectus recessions.
Linda, your turn.
Okay, so this is a great case that has to do with how you pick the next step of management. The first thing I would do with a case like this is to take 2 measurements. The first is, I think it's very helpful to know the amplitudes of convergence that you have left in this patient, both at distance and at near, because you don't want to create a situation where you fix a deviation that he's primarily symptomatic with at distance, but then he cannot read, he cannot focus at near. So just the same way I check this with patients who have a divergence insufficiency esotropia, I would check the amplitudes of convergence to know sort of how much play you have in the system, how much more you can weaken or reduce that esotropia. And the next thing I would check would be forced ductions. Is the medial rectus on the left still tight? Why is this returning? In terms of management options, it depends on what you've learned about convergence amplitudes and about the forced ductions. For example, if you have good convergence amplitudes and the guy can really converge to his nose, you might simply further recess the medial recti, just like we have to overly recess medial recti if you have a divergence insufficiency esotropia. You might, for this incompetence, consider a further medial rectus recession on the right, maybe with a Faden suture to restrict left gaze of that right eye, so get rid of some of that incompetence, or you could replace it with the now Scott variant, where you do sort of recess resect to get rid of that horizontal incompetence, or a greater recess resect on the left. It would be interesting to consider what would happen if you did a superior rectus transposition on that left eye, because you haven't done that yet. And that would increase avducting tonus in that eye. So if the medial rectus on the left wasn't tight, and if that wasn't restricting movement of that eye out, you might consider doing a superior rectus transposition. And if the medial rectus on the left is tight, you could further recess it. The only caveat to that is we do know that there is some degree of risk of an induced torsional or vertical diplopia. That risk is small, but that is a risk when you add now a transposition procedure. But that's the one thing you really haven't done, and that might really help you out. So those would be the things I'd be thinking about.
Thank you.
That's great. I couldn't have set you up any better. That's just perfect. I like to think of these as well as, as the adduction force and the abduction force balanced. And I didn't think it was balanced here because we still had a slow abducting saccade. So we didn't have a tight medial rectus. Because of that, I didn't think increasing the juice with a Faden was going to work, or recessing the medial on the contralateral side. And so I performed a left superior rectus muscle transposition temporally, just like you suggested. And I'm so glad you're discussing this, since you've written about this so many times. It worked great. I took the superior rectus, transposed it temporally, and he did really well in primary, but still didn't like his incompetence in left gaze. We tried him with a prism in primary. We tried increasing the prism because of his convergence amplitudes, like we talked about. But as soon as he went to the left side of the midline, he was still bothered by double vision. And frankly, that's not my experience with most of my patients when I do your transposition. They usually do really well. But this is where he is now after 3 surgeries about 2 months ago. And he's ortho in primary and in right gaze, but still has the abduction deficit, still has the ESO on left gaze. All right, so back to you again. What should we do next?
So you did the superior rectus transposition. Can you recess the medials more? I mean, it looks like you still got all this esotropic tone. And all the way, also, how did you get rid of that left hyper? It just went away.
That went away. Either that, the orthoptist just checked it differently. Had a different orthoptist.
If he still has good convergence tone, you could probably recess the medials, one or both more.
Yeah, I didn't do that. And the reason I didn't do that is I don't like a weakening procedure when you have a weak muscle that's balanced against it most of the time. I'd rather do a tightening. So
you could take, lateral rectus on the other side. You could take the inferior rectus.
I did the lateral rectus on this side. Let's go back to where it is. You got a lateral rectus there. I had resected it the first time, went back. I mean, this is a big dude. And went back and resected it a second time, pulled 8 millimeters out of it. And he is just absolutely happy. Now he's only a week or 2 out. We'll sort of see what happens next. But I think the challenge here and the take home message is, how do you try to determine what to do when you've got really a lot of incompetence, but not necessarily enough for transposition. And in this case, it's bilateral, and I like to try to balance forces.
So Sean, I have a quick question. We have a minute or 30 seconds before we go to the next presentation. You prefer to do the left lateral rectus instead of trying to do some procedure on the right medial rectus muscle. Was there a contraindication for you to go to the right medial rectus muscle?
Yeah,
other than that it has been recessed before? Were you kind of concerned with that?
Good question. I don't know if you can see my pointer here or not, but you know, the medial rectus on the right side, there's no limitation, but you've got a slow abducting saccade. And I think weakening the right medial, either with a FODN or with another recession, you can do that, but it's like kicking a dead horse. I mean, you're not going to improve abduction of a left eye because that lateral rectus isn't working. And I fundamentally don't think you can get a whole lot by putting a medial rectus back with a FODN. So, and that's why I went over and tightened this lateral, worrying a little about an XT over here in right gaze. But we were fortunate enough at least not to get one that's problematic at this point. But I can see why some people might choose the next as a medial rectus on the right with the FODN. I just don't find that as successful when you've got a paretic strabismus.
It's just that the procedure that you did before we go to the next could result in maybe some exotropia in the contralateral field of gaze. And if you're prepared for something like that, which has happened to me many times, I actually tried to address it by resecting the lateral like you did, but then I prepared to recess the contralateral lateral rectus muscle, believe it or not, and that turned to be a good alternative. But it's great.
So that's definitely a buckleyism. You say, well, what am I going to get from this? And so you resect the lateral and say, okay, over here I'm probably going to get an XT, so I'm going to recess this lateral over here as well as an adjustable suture. I think more is, less is more here. I just don't think you need to do it.
So let me ask you another question. You know, a lot of people who get
Linda, I'm going to move to the next case. We're running a little bit behind. I'm so sorry.
No problem.
Okay, so our next presenter is Mary Tabacoli, and his case is going to be discussed by Gina Hedari from Boston. So if we have time, we're going to go back. So Linda, please save that question, please.
All right, thank you for having me. So the patient is a 59-year-old African-American female who presented with sudden onset of double vision associated with severe headache that started about 3 weeks prior to the visit. The diplopia was horizontal, constant, and binocular. The headache was intense with a score of 9-10 out of 10, persistent with some response to oral pain relievers. Past medical history was significant for moderately controlled diabetes and hypertension. She brought the MRI CD without contrast, which was reported normal. So the ocular exam, as you see here, was in the normal range. The motility exam, as you see here, there was a left esotropia of 35 prism diopter in the primary gaze, increase in the left gaze with abduction deficit in the left eye consistent with the left six-nerve palsy. So far we have a six-nerve palsy, acute onset, vascular risk factors, neuroimaging was normal, although it was non-contrasted. So the first thing that comes to the mind is it microvascular 6? So in fact, microvascular six-nerve palsy is the most common etiology of six-nerve in neuro-ophthalmology clinic. But here something is not right. The patient had a severe excruciating pain and persistent pain. So microvascular nerve palsy are sometimes associated with headache or pain around the eye, but the pain is usually mild to moderate and often temporary. So then I decided to repeat the MRI, this time with and without gadolinium injection of the brain and orbit. So MRI, as you see here, showed an abnormal enhancement of the left cavernous sinus encasing the internal carotid artery and extending down to the base of the skull. The same lesion here you see in the coronal view, and also the abnormal lesion in the clivus area in the sagittal view. So in summary, acute onset of painful sixth nerve with such a lesion in the cavernous sinus was a differential diagnosis and diagnostic workup.
Jenna?
Great, thank you. This is such an interesting case, and I think there's a lot of different things to consider. Maybe we can go back one slide and we'll look at the neuroimaging and talk about the differential. First, let's kind of summarize what we have. We have, just by looking at her abduction, it looks like we have a complete sixth nerve palsy. So one of the things that we want to think about as we are working on the evaluation and the treatment plan is how are we going to manage our strabismus? In these cases, because we assume that there probably won't be spontaneous recovery, we might consider in 4 to 6 weeks use of Botox to prevent contracture of the medial rectus muscle as a temporizing measure as we're anticipating strabismus surgery later. And we can talk about the strabismus surgery, but most likely I would pursue it with medial rectus recession and transposition of the superior rectus, which is how we often manage our 6 nerve palsies at Children's. So that is kind of the long game in terms of managing the strabismus. But then in thinking about the etiology, I think there is some controversy in neuro-ophthalmology about whether or not in these patients who present with microvascular risk factors such as diabetes and hypertension, whether or not to pursue neuroimaging in the first place. And there have been a number of prospective studies now, most recently by Madhura Tamankar from Penn in a multi-center prospective study that demonstrated that even in patients with microvascular risk factors who present with isolated cranial neuropathies, often there will be other pathology, neoplastic, inflammatory, infectious. And so, there's growing body of literature that suggests that in these patients, even though it is more likely that there'll be microvascular etiology, that we should go forward with neuroimaging. And in this case, as Dr. Tapacoli demonstrated, of course, the neuroimaging should include should be with and without contrast, so we can demonstrate lesions that are inflammatory or infectious or neoplastic, et cetera. So I think that's one area that hasn't been fully resolved, whether or not to get the neuroimaging, but of course, in this case, it was essential. So some of the differential considerations may include, so in the top middle, we see this thickening of the cavernous sinus, and it could be consistent with meningioma, although the infiltration into the clivus is a little bit atypical. We might consider metastatic lesions. We can consider, there are some lesions that arise from the clivus, such as chordoma. It looks less likely to be chondrosarcoma. We might consider kind of the typical things that present in many different places, lymphoma, sarcoid, TB. And so I think what the neuroimaging demonstrates is this thickening. And if we look at the sagittal imaging, what's being shown here in the clivus is that it's dark and it's not bright. So it suggests that there's something infiltrating the clivus. So I think the differential is quite broad. We would be working with our neurology, neurosurgery, oncology, and some of the things that might enhance our understanding might include additional neuroimaging with CT to look for calcifications that are associated with some of these etiologies, possible LP, and then basically, CBC and sort of blood work associated with the differential.
Thank you, Jenna, very much. Thank you.
Excellent discussion. So yes, if I can move this forward. All right, so yes, we did the inflammatory workup first, considering inflammations and tumors, as Gina nicely discussed. We did this panel of blood tests and everything came back either normal or negative. Then considering, given the pain that the patient had, we considered the course of a steroid trial. Considering Tolosa-Hunt syndrome, it made no change in her symptom. Then I had 2 options of biopsy of the lesion or giving a metastatic workup, or we did the second one. I got the chest CT scan and mammogram. So the CT of the chest showed a nodule, suspicious nodule here, and the subsequent biopsy revealed a lung adenocarcinoma. The following PET CT here demonstrated a hot area of the left cavernous sinus, which was consistent with the metastasis. So the final diagnosis was metastatic lung adenocarcinoma presented with 6 nerve palsy. Patient underwent cancer treatment, and meanwhile, I injected the Botox and shot to the medial rectus, and it was partially fine, but she sometimes had to patch the eye. Follow-up MRI showed the resolution of the skull-based lesion, but the six-nerve palsy persisted. And then finally, we made a plan to do a strabismus surgery. So this was the preoperative measurement. And as Gina said, I do the same thing. I did a recession of the right medial rectus and also the left medial rectus, which was the paralytic eye with adjustable suture, and I transposed the superior rectus to the lateral rectus. Basically, I used the same procedure that was demonstrated by Dr. Donoghue and her associates with loop myopexy augmenting sutures. I put 2 sutures of 6 and 8 millimeter from the lateral rectus insertion and do intraoperative and postoperative adjustment. So pre-adjustment alignment was a little overcorrected. 10 PD of exotropia, 4 PD left hypo with no torsion. I severed the 8 millimeter augmenting suture and advanced the left medial rectus 1 to 2 millimeter, and the post adjustment was 2 exo, 2 hypo, and the patient was able to fuse. This is the post-update 1 alignment. She was still having the little bit of left hypo and exo, and she had no double vision. However, the hypotropia continued to get worse, and she started to have vertical double vision. So I repeat the MRI, made sure no overgrowthing the lesion, and it was fine. And then once the deviation settled, I did a second procedure. This was the deviometry before the surgery. The hypotropia was pretty comitant, and I did a left inferior rectus of 4 millimeter with adjustable suture, and no adjustment was needed, and she was fine, and she's still fusing in primary position and reading position with no double vision. So my take-home message would be, first, always look for and respect the red flags, which in this case was the pain. Non-contrast MRI is not an adequate test when tumors and inflammation are suspected. And superior rectus transposition for six-nerve palsy has been demonstrated to be effective with low profile side effect. And this is what I have in my experience, especially with intra and post-operative adjustment, yet the secondary vertical deviation may still happen. So if I have more time, I would like Dr. Donoghue and Dr. Gina, especially because they both had the same paper of this procedure, give us more comment and more suggestion. Thank you.
We can actually have, thank you, great presentation. Linda, you want in 30 seconds to say something about the vertical?
Really in 30 seconds, I think having
30 seconds.
30 seconds, the ability to do intra.
For the audience, it's for the audience, for us to learn.
Yeah, the purpose of doing intra and post-op adjustment is to maximize the possibility for excellent fusion, but there's no question that all transposition procedures carry with them a risk of developing a vertical deviation, whether it's a balanced transposition or inferior only, superior only, over time, because you're changing a lot of vector forces. And so sometimes you need to reoperate, just like you would for any other type of strabismus. I don't think that there is magic to doing this. These adjustments give you an optimal outcome initially, but there's still the possibility of deviation over time, just by an asymmetric transfer.
I think it's the experience that we all have, even though we think that we're not going to induce vertical deviations at the very end, we probably will induce and torsional as well. Thank you, Linda. So our next case is going to be presented by Dr. Jason Peragallo, and this case will be discussed by Dr. Sean Donoghue. Jay.
All right, so let me get this pulled up here. Okay, so here we go. So we have a 35-year-old woman who presents with double vision. Here's her past medical history. She does have a history of Graves' disease that was diagnosed when she was 25 years old. And she did have a right eyelid retraction correction surgery performed, a thyroidectomy, and has hypothyroidism. She did not have double vision at that time and didn't have strabismus as far as she knows. And prior to presentation, she developed severe dizziness, vomiting, and double vision, and was noted to have abnormal eye movements, and so neuro-ophthalmology was consulted. Her afferent exam, slit lamp exam, and dilated exam are all normal. There's nothing remarkable here. Her motility exam, though, is significant for a -3 adduction deficit in both eyes, and she does have nystagmus on abduction in each eye alone. So here's her motility exam, and you can see that she has a significant limitation of adduction in each eye, and she has an exotropia that looks larger on lateral gazes. And so this is demonstrated here in our orthoptic exam, and she has an XT of 40 that's basically the same on up gaze and down gaze, and larger on lateral gazes with an associated small left hypertropia. And then at near, she has a 25 prism diopter exotropia with a small left hypertropia. And so I'm going to leave it for Dr. Donoghue to discuss.
Sean?
Thank you. I appreciate it, Jason. Great case. Could you go back to the motility picture, please?
Sure.
So you've got a patient who has a history of thyroid disease and is relatively young, and then comes in and has this bilateral adduction limitation with bilateral abducting nystagmus. And the concern in anybody who has bilateral adduction limitations with bilateral abducting nystagmus is a bilateral internuclear ophthalmoplegia. And sure enough, this patient has, is at the right age group to have demyelinating disease, and could potentially have that, and has a distance near disparity where you've got a greater XT in the distance than you have it near. But the thing that's problematic here is this patient already has thyroid disease. And I don't like to give a young person two different diseases. I'd rather try to tie it in here. And so about a third of patients who have thyroid disease also have myasthenia. And myasthenia can have all different things that it mimics. And Patrick Lavin showed me a case a number of years ago where a patient had bilateral, what looked like a bilateral INO, including the abducting nystagmus from thyroid, from myasthenia associated with thyroid disease. And look here, your tip off, I think, is that right upper lid. That right upper lid is almost to the top of the pupil. To me, and look at the retraction of the eyelids. So I'm going to come and say, I think this is autoimmune disease, thyroid plus myasthenia, and not MS or some type of demyelinating disease that's producing a second disease in somebody with thyroid. I could be completely off, but I think that's the direction I want to go with this. And then we'll talk about management afterwards.
So before Jason speak about treatment, can you just, again, like in 30 seconds, will tell us what would you do if it turned to be a bilateral internuclear ophthalmoplegia? Would you operate on a patient with bilateral internuclear ophthalmoplegia, and what would you do?
Do you want me or you want Jason here?
No, to you.
Okay. Yeah. So the first thing I do I forgot to mention this, but to try to get at whether or not this is myasthenia or INO, is look at orbicular strength. Have them close their lids and you try to open. If you can open those lids, this is myasthenia. If you can't open those lids, then you got to be thinking this is an INO. Now, how would I manage this? If this were stable and this were an internuclear ophthalmoplegia, then I think that probably the best thing to go from that standpoint is bilateral transpositions. And Niraj Nathan and I produced about 8 of these who had bilateral INOs where we did an inverse Jensen procedure. Oscar Cruz and Joe Roper Hall have talked about doing INO surgery when it's unilateral with an R&R, and that works well. But when it's bilateral, I think you have to do some type of transposition. I just like the inverse Jensen. So instead of like you do for a 6 with the lateral, you move the muscles over immediately. The superior oblique doesn't get in the way. That's how I treat it in 30 seconds.
Thank you so much. Okay, Jay, is your...
All right, thanks. So I have to show you the MRI next.
Oh, look at
This is
that.
what she had. I was trying not to make it too complicated with multiple disease processes in the same patient, but she did happen to have thyroid disease and then later on developed what the typical signs for demyelination and MS, and is now on treatment for MS. But so here's her, the lesion on the MRI in the expected area, bilateral MLFs being involved in the posterior pons here. So on flare and after GAD administration. So internuclear ophthalmic plesia is the loss of adduction due to involvement of the medial longitudinal fasciculus. We know that adduction can be slowed or absent, and abducting nystagmus is one of the findings that we see in this as well. And convergence can overcome the adduction deficits at times. So here's where, and bilateral INO, is leads to a large angle exotropia, and there's loss of convergence in the quote unquote wall-eyed bilateral internuclear ophthalmoplegia. So let me go back to her motility again, and you can see that she's got an XT that's larger at distance than at near. And she had -3 limitation of adduction in both eyes. And so, I've definitely had patients where I've done transposition procedures on them for large angle exotropias in bilateral internuclear ophthalmoplesias. For her, here's what I ended up doing and what happened. So my plan was to address the limited adduction by improving the force there, and also address the left hypertropia. She probably had a small fourth or skew in addition. So I ended up doing bilateral medial rectus muscle plications of 6 millimeters with a left superior rectus muscle recession of 3. So what are your thoughts about doing medial rectus muscle plications for this problem?
Yeah, I think you have to tighten the adducting force somehow, whether you choose to tighten the medial rectus itself or to do some type of a transposition. I think you have to do that. It's not going to work to just weaken the lateral rectus. Like I said, I like the Jensen transposition. I haven't seen other transpositions described in large series here. And the reason I like the transposition, I think it gives you better force from the superior and inferior rectus. Both of those two muscles have good tonus to them. You can take them, you can transpose one or both of them or parts of them over there medially. My concern about the medial rectus is you don't have a lot of tonus. And so it's kind of like the kicking the dead horse again, like we talked about earlier. I think it's probably going to recur. I hope it doesn't. But especially with a -3 adduction limitation, I think you have to do something to balance the forces a little bit better.
Okay, so here's what happened. After surgery, she had -2 limitation of adduction. She's improved, but she's now got an esotropia of 12 at distance and 18 at near. Yeah,
not too bad to get this patient ET is probably great news. It's like a Turner palsy.
And so maybe, I think what I missed out on here was I should have paid more attention to what her convergence ability was, and maybe would have discovered that she had more adducting tone than I noticed just on her motility exam. But she was happy with prism glasses, ecstatic, but not my ideal outcome, but she was happy with it. So that's what ended up happening.
There is one question here for you and maybe for Dr. Donoghue. Do you wait for an effect of medication drugs? Do you anticipate any improvement at all?
That's a great question. So she had been treated with steroids initially, and started on, I think it was rituximab after her presentation. And I waited at least 6 months before doing the surgery. But after, if it doesn't improve after 6 months, then I go for surgery after that. I'm not sure what you do, Dr. Donoghue.
Yeah, I would agree. I mean, things are going to change here. You need to get her tucked into neurology because you're worrying about MS and other demyelinating episodes. And so you have to wait for the natural history. But typically the lateral rectus muscles are going to tighten, the medials are going to stay somewhat thin. And so once you've got stability, then you operate. But I would wait at least 4 to 6 months here too.
Thank you for a great case. Appreciate it.
All right,
Okay,
thanks.
so we're going to move to our next presenter, Dr. Linda Donoghue, and her case is going to be discussed by Mary Trabalocki. Linda.
Okay, thank you. I'm going to share my screen and let's see if that's the right one. Ooh, I'll go back up here. Sorry. Okay, so here we are. No conflicts. So our history is that of a 60-year-old intoxicated female who fell down a flight of stairs. She was obtunded upon arrival at a regional hospital. CT and MRI was done, among other things, and she had a non-displaced fracture of the right superior orbital rim, the lamina papyracea, anterior and lateral maxillary sinuses with orbital emphysema. But she also had head injury. She had frontal, parietal, and temporal lobe subdurals, and contusion with compartment syndrome, interventricular hemorrhage, and a frontal subarachnoid hemorrhage. And she was treated for severe closed head injury with very grossly elevated ICP and was in the ICU for quite some time. Here's just some random images, early CT of these non-displaced fractures around the orbit and orbital blood and emphysema, and later MR images showing some blood in the ventricles and some of the defects due to the subarachnoid hemorrhages. So ophthalmic evaluation in the ICU in this outside hospital was noted for intraretinal hemorrhages with some scattered cotton wool spots and disc edema. The above was attributed to Tierson syndrome and Purcher's retinopathy. She also had multiplanar nystagmus and vertical misalignment and diplopia with tilted vertically displaced images. Let's see if I can advance it this way. Okay. So she presented to our clinic a year later. She complained of intractable vertical and torsional diplopia. She had a prior history besides alcoholism of depression and hypertension, and she was on a host of medications, all of which are really non-contributory here. But here's the pertinent exam. She had, at this point, excellent best corrected acuity. She had a little bit of inferior oblique overaction on the left, and you can see the 3x3 diagram here. I can ask our discussant to discuss what you see here. And quite a bit of torsion. She had fundus 3+ excyclotorsion on the right, 2+ excyclotorsion on the left, double Maddox rod 13 degrees excyclo on the right and 4 degrees excyclo on the left. And she appreciated the stereofly at near with 14 prism diopters base in and 2 base down left eye, but the images were tilted, so she really couldn't fuse very well. And as a result, it really didn't even have a compensatory head posture. So this is a fairly straightforward case presented mostly to talk about the details of how you would consider management. Here's her pre-op motility. She doesn't look that misaligned. You can see in primary position, she looks quite straight. I'll ask our discussant to talk about what he sees looking at the motility.
Eddie, your turn. Thank you.
Yeah, so we can return back here.
You can go back to the motility exam.
Sure, absolutely.
So there's a number of findings that help us diagnose. That include there's a right hypertropia on the left gaze and a left hypertropia on the right gaze. So there's also right hypertropia present on right head tilt and left hypertropia on left head tilt. Ocular cyclotorsion exceeds 10 degrees and there is a significant ISO shift from up gaze to down gaze. And I think the constellation of findings is consistent with the bilateral superior oblique palsy. So head trauma is the most common cause of bilateral forceps palsy, which fits with this history. And in terms of differential diagnosis for bilateral superior oblique palsy, it is not common that subtle sign of bilaterality, like in this case, might be overlooked, especially in cases like this with vertical deviation primary gaze. And after surgery on one eye, the superior oblique palsy on the other eye becomes unmasked. The other differential in the context of trauma would be SQ deviation and ocular tilt reaction. However, in SQ deviation, usually the hypotropic eye is excyclotorted as opposed to the forceps palsy. Other differentials for this pattern of deviation in non-traumatic cases would be myasthenia gravis, thyroid eye disease, asymmetric sagging eyes that can present with a small angle vertical deviation. In terms of treatment, what I do, I would probably do given the asymmetric bilateral excyclotorsion, and since there is a vertical deviation, I would probably do a bilateral but asymmetric Haradaito procedure, and would secure a larger width of the superior oblique tendon and increase the tightening on the side of the hypertropia. The other option, which I don't have experience with, would be advancement of the entire width of the superior oblique, more on the hypertropic eye. That can be done with also adjustable suture. So you tell us what you did.
Okay.
Thank you, Mary, Linda.
Thank you. Thank you very much. This is fairly straightforward. I just want to point out some things about the motility, which you beautifully pointed out. The first thing is that here you have a patient with severe torsional diplopia, but when you look at her, when she walks into the clinic, she doesn't look that bad. And in fact, you know, she does have the classic features of a bilateral superior oblique palsy. Yet if you look at the plane of action of the superior oblique on the right and on the left, superior oblique doesn't look that bad. She does have the V pattern with some inferior oblique overaction, but the motility itself, the numbers that you just saw don't look so terrible. It's the severe excyclotorsion that's the clue and the key to treatment. So that's the first important thing. So what I did, so here's the diagnosis. Obviously, it's bilateral fourth nerve palsy because of the severity of excyclotorsion. Of course, it's classic after closed head injury, and it's something that's not that uncommon in a clinic. There's no brain scan lesion. She had no brain stem pathology. And so a skew deviation in that regard is actually far less likely. Also, the lack of that fourth step test and the difference in the torsion you'll see, but sometimes skew deviation will have the excyclotorsion on both sides. And once again, the biggest concern is the torsional diplopia. And here the superior obliques look fine, but you can appreciate the V pattern and the 17 degrees of excyclotorsion. So what did I do? There are many things you could have done. What I did was on the left eye, the Fels modification of the Harada-Ito, which involves advancing the anterior 4 millimeters of the superior oblique to a location approximately 10.5 millimeters away from its natural location to 2.5 millimeters above and about 8 millimeters back from the superior border of the lateral rectus. And this is done adjustably, so you can decide how much you want to do of this advancement of the torsional fibers. And because I really didn't know what impact this would have doing this unilaterally, because that was a decision whether to do this unilaterally or bilaterally, for that modest left hypertrophy of the superior rectus on the right was resected because might have been left with it, but then ultimately recessed back. I didn't need that procedure essentially. And for the XT that she had, the lateral rectus on the left was recessed. So we were able to induce about 24 degrees of encyclotorsion intraoperatively to counter the 17 degrees of excyclotorsion measured preoperatively in the clinic. And I just want to show you what you can do in the OR to help you decide how much to do. So what I like to do with cases like this, I'm sort of particularly interested in torsion, is to mark 6 and 12 o'clock and on the cornea and on the skin, and you do this with a corneal marker. So here you are with a toric marker, as our cataract surgeons would do, but it's key that you have to mark the skin above and below because you're looking at the change in torsion of the cornea in the course of the case. And here you are transposing, surgeon's view, the anterior 4 millimeters of the superior oblique towards the lateral rectus. And with your torsional marking, you can then see you've induced a certain degree of new encyclotorsion of the eye. And you can decide how much you want to advance that band, the anterior 4 millimeters of the superior oblique. So here she is post-op, seeing quite well, not much in the way of deviations, ortho and primary, minimal deviations, which are mostly phoric and side gaze, 50 arc seconds of stereo, double Maddox rod, no torsion at distance and near for over a year. So another question that comes up in these cases is how much do you need to overcorrect when you do a Harada-Ito or any variant, be it the Fels variant? And the general rule of thumb is that you do want to overcorrect because it tends to unravel itself. Yet in this particular case, I didn't really overcorrect that much. Here we started out with 17 and I induced about 24, but you do need to do some degree of overcorrection because it will weaken over time. And that's really why I presented this, mostly to talk a little bit about head injury, which we see commonly, and the other to talk about intraoperatively monitoring torsion so you can make a decision about what to do.
So Linda, just to clarify, your postoperative measurement of torsion was 7 degrees of encyclotorsion. Is that correct?
Yes.
Okay, thank you. All right. Yeah, great presentation. Thank you very much. So we're gonna move to our last case, and this is actually going to be presented by Jenna Hidari from Boston Children, and it's going to be discussed by Hilda Capó from Bascom Palmer.
Wonderful. Thank you so much. This has been a terrific webinar, and thanks to Dr. Velez and the Adult Strabismus group for AAPOS for inviting us. I've really enjoyed all of the cases and the discussion this evening. So I'm going to round out our discussion with a case. I have no financial disclosures. This is a 15-year-old young man with NF2 who presented for treatment of his torticollis. His right head turn has really been present since he was about 10 months old, but it has progressively worsened and it's associated with a great deal of neck pain. His medical history is notable for NF2. He has extensive intracranial tumor burden that we'll speak about a little bit later. Amblyopia in the right eye from a lesion involving the right optic nerve and retina. And he's had a couple of prior strabismus surgeries at the outside institution. So here's our young man. He comes in with his right head turn. His vision in the right eye is 20/150. Left eye sees well, and his head turn is approximately 20 to 25 degrees. His motility examination is characterized by limited adduction, elevation, and infraduction of the left eye, which manifests as a fairly large angle exotropia in primary position, worse in right gaze, and less in his preferred head position. So here is his motility. You can see in the middle part of the panel that he has this large angle exotropia. He can't really adduct his left eye to midline, so this is why we graded him as -5. Abduction in the left eye seems to be intact. And you can see that there's limitation of elevation and depression of the left eye. Here's the lesion in the right eye that has left him with poor vision in the right eye. And so this is a 15-year-old man, young man with NF2. He has marked torticollis and a left eye fixation preference. The prior strabismus surgeries have included a weakening of the lateral rectus muscle, so attachment 16 millimeters from the limbus. And because of some vertical misalignment, he's also had an R&R in the right eye. So Dr. Capó, how would you approach him?
Okay. That's a great case, Gina. Would you mind going back first to the fundus lesion?
Yes.
Because I think this fundus lesion is important. I believe this is probably a combined hamartoma of the retina and the RPE. And this is suggestive of NF2. So even if you see this and you don't have a diagnosis, you have to suspect NF2 and probably consider genetic testing because it can be a presentation of NF2, even if you have no other signs at the time. So whenever you see a child in clinic with this, keep in mind NF2 and order the genetic testing. So it's great that you brought this up. And we can go back to the motility now. So here we see a young man, as you mentioned, he has a limited adduction of the left eye. He cannot really elevate the left eye either. And he has limited depression as well. He has a small hypotropia according to your measurements, but a hypotropia was probably worse before because he manifested as a secondary right hypertropia because the left eye is his fixating eye. So that explains why he had a vertical R&R on the right eye to bring out the right eye down. I think at this point, we need to focus on surgery in the left eye because that's the eye that is driving the face turn. That is the fixating eye. So doing surgery on the right eye is not going to correct the face turn. Options, I think we need to go back to that lateral rectus muscle. And it was already back at 60 millimeters from the limbus, but I think there's still room there where we can further recess the muscle. That would be an option. I think even probably better than recessing it. If the muscle is not too tight and it hasn't shortened too much, you may want to consider a transposition, a nasal transposition of the lateral rectus to the medial rectus insertion. I think that would be ideal in this young man. My only concern would be that the lateral rectus may be shortened after a prior recession, and you may not be able to get it all the way nasally, but they may be something that you may want to attempt. Other options would be kind of to cripple the lateral rectus and do a periosteum fixation. I would not like to do this in a fixating eye, because I think that would limit the movement and it will be unpredictable. Other options, I think transpositions may not work very well in a patient with a third nerve with underaction of both superior rectus and inferior rectus muscles. So I think nasal transposition of this vertical recti are not going to be very effective. I think at this point, I would probably try, again, first a nasal transposition of lateral. If that's impossible, then we recess it and do a medial rectus resection. If all that fails, we can always do a T-plate and nasal fixation of that globe. But again, that would limit the movement of his fixating eye, so that would not be ideal. So I'm just curious to see what you have done and what the outcome was.
Thank you. That's a beautiful discussion. Let's forward. Let's see if I can forward. So first, yes, I think the dilemma here was that he was fixating with his paretic eye. So I completely agree with you that the focus here is working on the left eye and trying to get it into a better position so he doesn't have this marked torticollis. And one of the things that I wanted to highlight here in the neuroimaging is that this left third nerve palsy was secondary to a third nerve schwannoma. And so even though the hallmark of NF2 is bilateral vestibular schwannomas, many of these children will have non-vestibular schwannomas, most commonly ocular motor schwannomas, as well as trigeminal schwannomas. So in this case, he has bilateral trigeminal schwannomas. We see the large one on the right, and the arrow is pointing to the oculomotor schwannoma. One of the interesting things about these schwannomas is that in distinction to the vestibular schwannomas, these non-vestibular schwannomas are really not fast growing. They are rather slow growing. So we're not going to fixate so much on the management of the schwannoma itself. And I agree with you. So I think in this case, I was hesitant to pursue the lateral transposition of the nasal transposition of the lateral rectus muscle, because I thought the lateral rectus would really be too tight and foreshortened. I thought about disinserting it and fixating it to the orbital rim, but in truth, when we went in, it was so tight and so far back, very difficult to access, that I just disinserted it. It was not even safe really to get suture on the lateral rectus. And although the medial rectus doesn't have a great deal of tone, I still created some restrictive strabismus by resecting the medial rectus, and then I transposed the superior oblique nasally. And I think that it's the superior oblique transposition that's going to form some sort of tether to hold the eye in place. So I agree with your approach wholly. And I think if he had not had prior strabismus surgery on the lateral rectus, the nasal transposition is a great option. But in this case, really, it was very difficult to even get to the muscle. So in the interim, he was started on a clinical trial with brigatinib for chemotherapy of his really extensive intracranial tumor burden. And he came back, this is post-operatively several months later, and I think he's really pleased with his head posture. He notices, now the left eye is fixed in place. He does notice some strabismus on the right eye, but of course, try to encourage him that that is really secondary to the fact that his torticollis is substantially improved. He has some improved adduction of the left eye, but interestingly, even though I disinserted the lateral rectus, we still see some abducting force, and you can see that here. Now he can get to midline, but I'm still just marvel at how the lateral rectus still is intact somewhere. And I think we couldn't completely inactivate it because sincerely, it was just too foreshortened to really detach it and fix it to the orbital brim. So just in summary, as Dr. Capo mentioned, there are a number of findings on the examination, which if he didn't have the genetic diagnosis of NF2, should prompt you to pursue the genetic testing. And with respect to strabismus, ocular motor schwannomas are common in NF2, but these are fairly slow growing. And so we don't necessarily need to wait for chemotherapeutic treatment of the schwannoma in order to pursue strabismus surgery. And as we've counseled him here, it's possible and likely that his exotropia is going to gradually and incrementally manifest again. But if we can gain some time by improving his torticollis, that's our surgical goal.
Thank you, Jenna, and thank you, Hilda, for a great discussion on a very difficult case. So this is the end of our case presentation. We actually have 5 more minutes to end this workshop. So I have asked our panelists if they can actually, if they have 30 seconds really to say something, if they want to say something about any of the cases, they're welcome to say it. I think, Linda, you were going to say something on occasion. Sorry, but I interrupted because we were running behind at that point. I don't know if you remember what you were going to say. Okay,
I do.
go ahead.
It was a question to Sean on his case with the abduction deficit. Had you considered the possibility of completing transposition by adding an inferior rectus transposition to the superior rectus transposition, simply because that might have been among the possibilities?
I don't know if
John may not be here.
Sean
I
is
mean,
here,
it's just,
but I think it's a great thought. I think that's definitely a possible.
There we go. It
Oh,
took me
Sean
a
is
while.
here.
It took me a while to
There you
get
go.
back to where we were. Yeah. Sorry, Federico. Yeah, it took me a while to get back to that. I really had not thought about taking the 4th rectus muscle off of the eye at that time. I know you all have written about doing an inferior rectus transposition isolated after superior rectus transposition, but that sample is still pretty small, and I worry about a vertical, and I kind of do worry about anterior segment ischemia. And if moving the superior over didn't work, I'm not sure that moving the inferior will work, which is kind of one of the reasons I presented the case. It wasn't a great answer, and I don't know what to do for the 5th surgery because I know in 6 months he's going to be back.
All right. Anybody else has any comments about any of the other cases? It doesn't need to be the one that you were assigned to discuss. So I actually, I learned a lot. I have to say that I did not know any of the cases that we're presenting here. So like everybody else here and the attendees. So I really appreciate very much for all the teaching that you gave us today. I think all the cases that you have presented were very challenging, and your discussion has been really outstanding. So on behalf of AAPOS and the Adult Strabismus Committee, we want to really thank you for the time in preparing your cases and all the dedication today to participate, and the discussions were just fantastic. I actually just want to summarize a couple of the points that for me were really everything was very interesting, but I mean, this pseudo signature palsy from Dr. Capos on the hydrocephaly is incredible. On the CCF fistula case, I mean, the comments about convergence amplitudes and the management of lateral incompetence is really important. I mean, for me, the painful cranial nerve palsy, that's really a critical point to definitely feel like it is really a critical point from that case. Definitely for not every patient that has limited A deduction has INO, so we have to really think about it. So for the large torsional diplopia, I think the point that Dr. Donoghue mentioned of the overcorrection about Harara-Itos, I feel like we always have to teach our trainees, fellows, and residents that having an overcorrection after Harara-Itos is ideal. If you don't have it, just prepare for the next surgery, and probably you will be presented a case on a webinar like this in the future for sure. And then the importance of recognizing this weird condition like tumors affecting cranial nerves, and that point of not transposing medially tight lateral rectus muscles is really critical as well. So again, I don't know if anybody has a final comment. If not, I want to thank you and say good night to everybody. Thank you very much.
Thank you. It's been a pleasure.
Been
Have a
great.
good
Thank
Thank
night.
you
you.
all for being
Thank
here
you all for
today.
attending.
Have a
Very good to
wonderful
have us
night.
here.
Thank you.
Bye. Thank you.